So we're with Dr. Robert Chase at his farmhouse on May 8th, 2011, being interviewed by Barry Noon. So Barry, please go ahead.
Thank you, Jim. We were talking a while ago about the integrated program. And,
Yes.
And it's now a common pathway and may in the future become the common pathway for training.
Sure.
And this was all started as out of your head in the early '60s at Yale and late '50s at Yale, and then you implemented it in 1964 or so,
Right.
At Stanford. Can you tell me why you thought about that? Why was this something that you thought was important to have?
Well, I have to say that going through the Yale program, I went through the entire residency in general surgery and thoracic surgery at Yale before I had any knowledge of plastic and reconstructive surgery at all. And then during the war, I was taken out of residency training to go, first of all, to Fort Monmouth in New Jersey, Signal Corps headquarters. And then the Army, thank the good Lord, sent me to Valley Forge Army Hospital because they thought I could get credit toward my boards by being in Valley Forge. And believe it or not, the Surgeon General's office called me and said, why don't you drive down to Valley Forge and see if that's good, or you'd like to go there. Well, I couldn't believe that they were giving me an option. But I went down, looked at the situation there, and found that general surgery there was not to my great interest, but I bumped into Earl Peacock, who was running the hand surgery unit there with an enormous number of patients from Korea, since we were one of the only 2 hand centers at that time, unlike World War II when there were 7 such centers. And so I called back the Surgeon General's office and said, yeah, I would really love to go to Valley Forge Army Hospital, but I'd like to go in the reconstructive hand surgery unit. They said, fine. So I went down, and that's how I got interested in hand surgery. Bill Littler was our consultant, came down every 2 weeks from New York and helped us with the more than 200 hand patients that we had in at all times in the holding company, so-called, waiting for surgical reconstruction. And so I got very interested in hand work and learned an awful lot about it from Earl and from Bill Littler, of course, who regularly operated with us when he did come down. And so I got a chance to see Bill's technical expertise and his general judgment and his imagination about caring for hand injuries or hand issues of all sorts. So that's how I got interested in hand surgery. Well, after the Korean War was over, I went back to Yale to finish my residency training. And by then I was a moderately good hand expert. And so even as a senior assistant resident and finally chief resident, I was constantly called upon by the local practitioners to help them with hand cases. So I got to be known as a hand surgeon as well as a general and thoracic surgeon.
So then,
at the end of my residency at Yale, I took off and went to Italy, still in the Army, and spent 3 years there. And at that point, I had enough expertise in general surgery so that I was really the only surgeon in a hospital for 2,400 soldiers and their families, and had a terrific experience there. And after 2 years, I was having so much fun there that I called the Surgeon General's office again and said, could I extend? And they said, could you extend? Of course you could. So we stayed for 3 years in Italy. And during that time, I had some very interesting experiences in all kinds of surgery, whether every specialty, because there was no one else who would do anything surgical, nor would they do anything obstetrical and gynecological. So I was OBGYN, surgery, neurosurgery, orthopedic surgery, whatever.
delivering babies.
Yes. And the time to do that is at the end of your chief residency, when you feel there's nothing that you can't do.
Right.
And so I had a great experience there. And when my time was drawing close to getting out of the Army, the professor of surgery at Yale called me and said, would you come back on the faculty at New Haven? And I said, yes, but you know, I've gotten so interested in reconstructive and plastic surgery that when I come back there, I want to have credentials in plastic surgery so that I can set up a little plastic surgery program. And I said, where would you recommend that I go to do this? And the professor said, well, I don't know a lot about the plastic surgery units, but I know Milton Dupertis in Pittsburgh, and I know him to be a great surgeon. So that helped me decide where to go, because I went from the Army to Pittsburgh for 2 years to get my credentials in plastic surgery before going back to Yale. Went back to Yale and set up the first plastic surgery program at New Haven. And that's how I got started in the field. And it's probably more than you wanted to know.
No. But when you went back to New Haven, you said, I have all this experience in general surgery, thoracic surgery,
Right.
even delivering babies.
Right.
So we really need to train our plastic surgeons in this entire area of
Yeah.
surgery
You're right to bring that.
before we
Yeah.
make them plastic surgeons. So
Yeah.
how did you come to that leap?
Well, you're right to bring that up again, because by then you can see that I had spent about 6 years in surgery at Yale, but I had 3 more years that were spent in the Army, having further experience, then 2 years at Pittsburgh in plastic surgery, without ever getting to the level where I was either in practice or an academic surgeon. And I said, gee whiz, the number of years that I spent, and the time that I spent doing things that really are not at all essential for what I'm going to be doing in the future, doing reconstructive and plastic work. It doesn't make a lot of sense to me to insist that people train fully in general surgery, which itself was a specialty by then. It didn't include orthopedics, it didn't include neurosurgery and the other specialties. To spend 5 years in general surgery to get your boards before even starting in plastic surgery didn't make a lot of sense to me. It became very clear when I got to Pittsburgh, where I had had all the experience I had at Yale, completing the general surgery and thoracic surgery residency, all the experience I had at Valley Forge, and when I went into the operating room the first day at Pittsburgh as a new resident in plastic surgery, they started to tell me how to hold a knife. And I said, wait a minute, you know, I think I've done this before, and I really don't need to go way back through all of that again. I've been through all of that. And it occurred to me right then, and for the 2 years that I spent in Pittsburgh, that a lot of the training that I had was either superfluous or irrelevant to what I was going to do. I would have been far better off to have had a little bit more experience in orthopedics, or a little bit more experience in neurosurgery, things like that. And I said, we ought to think about redesigning the program in plastic surgery to, first of all, save time so it doesn't take quite so many years, and second of all, to change the experience and make more of it relevant to what a plastic surgeon eventually is going to do in his practice. So it occurred to me that we ought to think about that, and the things that I showed you this morning on those slides points out what we thought about before deciding that we were going to try to accept people at Stanford when I got there as head of surgery, that we were going to set up our program so that some of the interns we took were at least planning to possibly go into plastic surgery. Some were planning to go into orthopedics, some were planning to go into neurosurgery, and so on. So I said, let's identify them early so that they can do simple general surgery early in the game and simple plastic surgery early in the game. Mm-hmm. That is, early in their surgical training. And then to do the more difficult surgical procedures as time went on, in surgery, orthopedics, or whatever, as well as in plastic surgery. And then end up with a shorter term in plastic surgery alone. and it gave us the opportunity to take some of the extra time that would be saved to do some more imaginative things, like send each of our residents off for a year to work with Bill Littler in New York, or with people in Europe, or whatever, so that they'd come back for their chief residency in plastic surgery, not as sort of one of the boys, but coming back with some new information. They had a great pride coming back in maybe knowing more about craniofacial surgery than the chief, you know.
Well, we all knew, those in my era, finishing medical school in '65, and that we knew about this, what we were calling an experimental program at Stanford.
Yeah.
You know, what medical students were calling an experimental program at Stanford. And it showed a tremendous amount of creativity and innovation and all that, but it took a quarter of a century
Sure.
to catch on. And
Well,
why was that? Why did
I'll tell you
why
why.
did it take so long to catch on?
I'll tell you why, I think. You and I have both, well, I've been on a board of plastic surgery,
Yes.
and you get fairly fixed in your ways as you work on a board like that, and you can't conceive of there being a major change in the way things are done. And so you develop sort of a resistance to change. And I think there was that resistance to change in the Board of Plastic Surgery when we first started our own integrated program. There was a major objection on their part to accepting people for examination in plastic surgery who had not already completed their boards in general surgery prior to the usual time in plastic and reconstructive surgery. So there was a natural and understandable resistance to that kind of change. It appeared that we were diluting the experience of the surgeon who was becoming a plastic surgeon. The fact is, I don't think we were diluting it, but we were changing its configuration. So the experience was somewhat different, except for the final year or two of true plastic surgery.
Yeah. You may or may not know that that thoracic surgery is doing this now.
Oh, really?
They have cut back. They've cut back their full training in general surgery requirement, and there's a pathway that you can do after 3 years or so, or maybe a little more of general surgery, and then go on and do thoracic surgery training.
Yes.
So that seems to be a real revolutionary change. And that's,
Well, the other thing we talked about was the so-called basic surgery examination, which I was a great advocate of in the old days. Having people who go into surgery, any of the surgical disciplines, would generally start in general surgery. And I thought after the first 2 years of general surgery or so, maybe it would be good to give them a basic surgery examination that would deal with the sort of things that one deals with no matter what surgical specialty he or she is in. The use of antibiotics, you know, things, the customary things. And if they passed that examination, then they could go on and start to specialize right away after that. Mm-hmm. But that failed miserably over time at the ABMS and other places, because once again, we're dealing with people who had been accustomed to training in certain ways. They thought it was really the way to do it, and they were resistant to change. And the board was resistant to change when we started our integrated program, no question.
we tried to resurrect that basic surgical exam about 10 years ago, and only in plastic surgery, and using it as a pathway in plastic surgery to work it in, and it never went anywhere again.
Yeah.
And this was at that level. But you've been primarily a hand surgeon most of your career.
Yes.
And you early on, when you went to Stanford, you worked with orthopedics closely in developing a hand service, correct? I mean,
before that at Yale.
Yeah, Yale you did.
Yeah.
Okay.
Actually, we set up a hand unit at Yale, and Wayne Southwick, who was then the head of the Department of Orthopedic Surgery, and I got together and said, look, right now, patients come into the emergency room and they can either go to orthopedics or plastic surgery, and if they have a hand injury, saying, why don't we get together and have it one unit? And that's how we started
Yeah.
with orthopedics and plastic surgery together, forming a hand unit, a hand center.
Then the ABMS, at the ABMS, what happened is that in the mid 80s to late 80s, there was a push by specialties to make a certificate of added qualification on the original certificate, so that orthopedics, plastic surgery, and general surgery, all who were involved in hand surgery, were together to make a certificate of added qualification. This caused a certain amount of consternation in plastic surgery, because orthopedics had already verticalized, or really was moving toward a subspecialization.
Yeah.
And plastic surgery did not want to do that, because they wanted to keep the corpus of the specialty intact and not split off into subspecialization.
Right.
And so some did and some didn't, and go along with the certificate of added qualification. Do you have any thoughts on how that came about, and where we're going, where we went with it, and how it stands now?
Yeah. Actually, it's kind of interesting, at least at Stanford, the Hand Surgery Center, which I'm bragging now, has my name on it, the Chase Hand Center, remains part of, quotes, general surgery. So does plastic surgery. It is not a separate department at Stanford. And the two units are housed together and work together regularly, plastic and hand. The orthopedic surgeons are also in the hand unit. So they'll either be a hand orthopedic surgeon, a hand plastic surgeon, but they're in the hand center, if you know what I mean. So they all work together in the hand center. And I don't know whether that's the right way to organize it. I understand the desire not to break up a specialty into further subspecialties. And but
At the board, when this was all discussed in the late 80s, and orthopedics and general surgery moved ahead with it, there was a lot of resistance on the plastic surgery board to join.
yes,
And after much discussion and much hand-wringing and study, the board narrowly voted to join the CAQ with the other two specialties. And it's gone along, and what's come out of that is a growing relationship. Probably the best relationships that we have at the ABMS are with general surgery and orthopedics.
yes.
And I think that a lot of this has happened because of communication among the specialties over the years. And but there still is a problem here with the plastic surgeon who is practicing, who has a general practice of plastic surgery, who wants to do hand surgery also, and doesn't have a fellowship in hand surgery.
Yeah.
So that's where we are with that.
Well, it was interesting early in the development for me when the Hand Society was first developed after the war, after World War II, that hand surgery was done by and large by general surgeons and plastic surgeons and orthopedic surgeons. And the Hand Society was made up of that kind of a mixture. Slowly but surely, general surgery became less interested or less involved in hand surgery, and less involved in head and neck surgery, and less involved in several other things. It became the same kind of a super specialty, general surgery did, as all of the other surgical specialties.
Right,
Oh,
right.
it liked to claim the fact that it was surgery, and all of these other things were sort of units of surgery.
Right now, as the Joint Committee, which is has representatives from all three boards. General Surgery has 3 representatives from each of the 3 boards for a total of 9. In general surgery, the American Board of Plastic Surgery's representative to general surgery is usually the person who's on the Joint Committee.
Sure.
So we now have 4 representatives to the Joint Committee instead of 3, and that's how it worked out, because the general surgery, although they have been the administrative agent, now it's orthopedics, they've been the administrative agent, it has been a dwindling number of general surgeons.
Yeah. Well, it was interesting for me to go to Stanford as head of the Department of Surgery because at that time it included orthopedics, neurosurgery, urology, ophthalmology. It included every sort of cutting specialty. And slowly but surely, each of those has become its own department. And each of those departments is now at least the size, if not twice the size, of what our whole department was when I got there.
Plastic surgery, academically, plastic surgery nationally is trying to have departmental status. And I don't know at last count, but it's roughly around 15 or so departments of plastic surgery. You think it's a good thing? Or do you think it should be integrated?
I don't know. For us, it's been helpful at Stanford because of the nature of the institution for us to stay with general surgery. And I think, particularly since Tom Crummell got there, he's been very good about paying great attention to what plastic surgery's needs are. And so for us, it's been just fine to stay within the general surgery bounds. The other units could hardly wait to become departments, and they're all doing exceedingly well, I must say. But so is plastic surgery as a part of quotes, general surgery.
And Dr. Crummell was a sitting director of the American Board of Plastic Surgery.
That's right. That's right. And he loved that, by the way. He talks about it repeatedly with me. He enjoyed the years of working with the board.
So you were certified in 1960. Do you remember roughly when you became a director of the board?
Boy, I just don't remember that.
But that's not important. We have those dates.
You do?
Okay.
Okay.
We don't have to remember that. But
Yeah. No, I really don't remember.
But when you can remember being on the board.
Oh, yes, and I had a very good time on the board. I enjoyed that.
What were some of the issues that came along? The challenges that had to be faced back then. Right now, it's maintenance of certification. I mean, it's enormous from the standpoint of what we need to do.
Well, I guess maybe during that time there was discussion of the sort of sub-certification, that is, the special competence in various branches of surgery. And I suppose you're still talking about that. Mm-hmm. Is there a special competency in aesthetic surgery?
What we handled that in I think a very positive way, because we were this isn't supposed to be my interview, but it's Dr. Chase's interview. But we handled back in the late 90s. Well, yes, in the mid to late 90s, we were concerned about fragmentation of the specialty if we went off into subspecialization. Yeah. Versus unity of the specialty. The hand was already doing this, but that was being done with two other specialties. It wasn't being done by us primarily. So what we decided to do, in 1995 was when we first gave out our first time-limited certificates.
Yes.
So those people in 95 and after needed to at that time recertify. And we were trying to struggle about how we would do this recertification. So we looked at what was going to happen at the ABMS, and I was then on the board, on the executive committee and on the board of ABMS, and we saw coming down the road maintenance of certification. So we wanted to address subspecialization in maintenance of certification and set up our recertification in the same line, so that would address the fragmentation issue, and it would address those people who wanted to subspecialize and be recognized for doing something without giving them an extra certificate.
Yeah.
So we set up the maintenance certification program to include 4 areas: comprehensive plastic surgery, craniomaxillofacial surgery, cosmetic surgery, and hand surgery, so that they could take their examination in any of those areas. Or now it has evolved to practice assessment modules in each of these areas and what have you. So we were fortunate we were late getting into recertification because we could set up our maintenance certification program to recognize subspecialization without really fragmenting the specialty.
Sure.
So that worked well.
Yeah.
And so we don't have to worry about it now. And back in 1998, there was at the Aesthetic Society, they were secretly talking about making the American Board of Aesthetic Plastic Surgery, and leaving the American Board of Plastic Surgery, and setting up an examination. And I had just taken over. I was 1 year in this job, and we never had anybody before me. And so I called up my friend Gene Curtis, who was an aesthetic surgeon, and he is former chair of the board. And I said, Gene, what's going on? And he said, the train's already left the station. It's too late to do anything about that. So, well, we're going to have to try to do something about it, because this isn't going to work otherwise. So that's what stimulated the whole. We then formed advisory councils. So each area, hand, craniofacial, cosmetic, they have advisory councils from the specialties that advise the board on areas of subspecialization, and then it sort of acts as a farm system for the board, because these guys on the advisory councils lots of times become directors of the board.
Yeah.
And so that all happened back in 99 and 2000. And so that's how we address this subspecialization. So we don't have to give sub-certificates. We don't have to go to the ABMS for a sub-certificate. Guy takes the exam in cosmetic surgery, and when he recertifies or maintains certification.
Now I've got a question for you.
Right. I figured that.
When did the name of the American Society for Plastic and Reconstructive Surgery become the American Society of Plastic Surgery, leaving out reconstructive?
When, I'm not
And
sure.
why?
But about 3 or 4 years ago. Jim, Dr. Wells can tell us a lot more about that.
That happened during the tenure of Dr. L. Zook as president of ASPRS at that time. And the push came in the 80s during the HMO era. And all the messages we were getting back from the insurance companies were, we don't understand plastic and reconstructive surgery. We understand plastic, we understand reconstructive, but we feel the names together are confusing for us to deal with. So after lots of discussion and several negative votes, the society elected to drop the name reconstructive, not meaning that we weren't doing reconstructive,
Right.
but that plastic encompassed the concepts of cosmetic and reconstructive.
Yeah. Okay.
And we tried to educate the public on that concept, that plastic doesn't just mean cosmetic, it means reconstructive as well. So that's been the evolution. There's been movements back and forth, pros and cons, about whether it was a good decision or not.
And one of the arguments was that the American Association of Plastic Surgeons didn't have reconstructive in it, and the American Board of Plastic Surgery didn't have
That's true.
reconstructive in it.
No, I can
So
understand
that's
all
how-
that.
That's how it all
The
happened.
reason I asked the question is that frequently at cocktail parties, people ask me, what do you do? And I always say, I'm a plastic and reconstructive surgeon, for obvious reasons. Otherwise, the person at the cocktail party would come and say, now I've got this little, the wrinkles here, and I said, no, I don't really do a lot of that kind of surgery. My surgery is more reconstructive.
Well, that's been always the issue of branding and identifying ourselves to the public. And,
Sure.
and at times it's been perceived as being somewhat schizophrenic.
Yeah.
If you watch the news at 11, they tell stories predominantly about aesthetic surgery and the
Exactly.
things associated with that. It's been a difficult uphill climb when we've dealt with the media to get them to talk about reconstructive surgery.
Sure.
A number of years ago, you may have paid attention to the TV show Extreme Makeover. That was during my time as president, and it was a big debate about, we tried to get them to move into the reconstructive arena, and it did not.
Yeah.
The Patience of Courage, which is an acknowledgement now in the opening ceremony of ASPRS, is to remind us about our reconstructive background and how we change. So
Sure.
we haven't given up reconstruction
Right.
at all.
No. I
but
recognize
I understand
that.
it.
So back in those days, when you were a director of the board, were you dealing with fragmentation, subspecialization?
Yes, there was some discussion of that then. It hadn't happened really seriously at all, but there was a lot of discussion about it, about the separation of the various components of the specialty, or the fear of that.
But still, even when you were director of the board, there was resistance to going ahead with more integrated programs.
Absolutely, yeah.
And at the ACGME.
Yeah, because that was a
and
change.
Developing that. But I imagine when you were director, you pushed for that a little bit.
Yes, yeah, we discussed it. But I was off the board by the time we really got into it.
That's right. That's right. That was a time.
And the board was, I always say they were very resistant to the idea. In general, I would have to say if they'd taken a vote, they would have opposed the idea. But they were not, not nasty about it or not overtly, totally resistant to it. But they did bring up all those things that I mentioned about why do you want to do this?
Well, I knew about this program, obviously, that you had at Stanford. We had talked about it in the 70s.
Yeah.
And about 1988 or 89, ASPRS decided to have a retreat of the entire specialty. And they said, they wanted the board to send representatives to this retreat. And Fritz Barton and I were the freshman first-year directors on the board, and I said, you guys go to this retreat at ASPRS. We're not having anybody else go to this thing. They didn't want to hear about this. So we go to represent the board, and then there were representatives from all kinds of different organizations. The Aesthetic Society had representatives. So we're meeting in Chicago, and then they looked at us and they said, Noon and Barton, you break out in a breakout session for the whole morning, go to your room and come up with some ideas about how to change training. Well, that was easy. We went to our room and I said, Dr. Chase, I talked 15 years ago when I knew him well, and he was then 10 years after starting this integrated program concept. Let's go back and tell him to put an integrated program in. And this is how we should change training. But then it was ripe and was ready. So the specialty was ready to accept it. And so we went back in the afternoon and after the breakout sessions and came up with this concept. And it sort of got grassroots level support, not board support, because the board. But here are two guys on the board who are coming to tell us that maybe we should have this change in paradigm, this paradigm shift. And so that's how that got some traction from the grassroots, and then the board caught on.
That's interesting to me, and it's also interesting to me because I just heard it from you that the thoracic board is thinking about.
Well, they have done
doing
it.
the same thing. They have done it.
They have a short pathway.
Now, I can't recall. Neurosurgery never did require full general surgery.
Neither did orthopedics and urology. Yeah. ENT, they're all cutting back on their requirements of general surgery, recognizing that they need to do that.
Yeah, well, general surgery itself is a specialty.
The only specialty so far that has not gone away from the general surgery board requirement is colon and rectal surgery. So colon and rectal surgery still wants fully trained, required general surgery. And I guess that makes sense.
It does.
In that particular specialty.
Because that is general surgery, as far as I'm concerned.
Colon and rectal surgery.
Yeah.
So, Dr. Chase, if you were talking to young residents or people thinking about plastic surgery today, what message would you give them based on your long history in plastic surgery and what you might look at your crystal ball?
Are you asking me, would I urge such young people to go into the field of plastic surgery?
That could be part of it, absolutely.
Well, I certainly do, and as a matter of fact, I have to confess to you that I'm in the middle now of doing a clinical correlation lecture for our first-year anatomy students. The clinical correlation lecture is given at the end of a dissection period of one region. I'm just finishing, for example, a clinical correlation lecture on the head and neck. Well, so much of the work in the head and neck is in our field that it was easy for me to show why a student ought to know about the anatomy related to various and sundry surgical procedures and demonstrate those procedures in slide format. Well, I've been doing this for a number of years, and when I stopped doing it, the people in plastic surgery got very upset because a number of the students in year one who went to that lecture and saw what was going on in plastic and reconstructive surgery said, that's for me. And so there was a little bit of salesmanship there, I suppose, about our specialty at a very early stage in the development of a young physician. That was really fun for me, so much so that I'm now trying to put it together with audio so that they can have it for their little iPods to look at the clinical correlations and actually answer the question, why do I need to know this fact about the facial nerve or this fact about any of the structures in the head and neck?
Well, given the integrated programs today where medical students have to make an early decision about what pathway they want to go to,
Yes.
wouldn't this help them make their minds up and certainly inform them? There are many medical schools who don't have access to plastic surgery.
To make up their mind to go into the right specialty like plastic surgery.
What do you see as the future advances in plastic surgery? Where are we going?
Well, I don't know. That's a hard thing to say, except that, I've been at this business for 60 years, and I've seen such incredible advances that when I think retrospectively, I say, my God, if we could only have done microsurgery when I had this patient who required a transfer of something, instead of a vascularized pedicle flap. And it's kind of fun now to show medical students a tubed pedicle flap, which they've never heard of, to carry something with its blood supply to a separate area. And one of the things that I do at the end of this clinical correlation lecture is to say, I'm going to give you an example of why it's great to be a physician. You're all young budding physicians. I'm going to give you a couple of examples. One of which was a kid I took care of in Italy now 60 years ago, almost 55 years ago, when I was in the Army. Little boy who was then, I think, maybe 7 years old, got hit by a car in Italy and dragged along the roadway, which was in gravel, sharp gravel, on his face. And it destroyed the whole side of his face. I mean, it just ripped this all apart. And I've got these pictures of it that I show them, see, and it's a terrible looking picture, all black and white, because we didn't have color in those days. Anyway, and then I go through the reconstructive procedures we did on that kid while he was in Italy. And it required moving, transferring vascularized flaps here and there. It required a tube pedicle flap. All of these things that we don't really do very much anymore. And before I had completed the surgery on that kid, his father got orders to return to the United States. And I said, oh my God, what am I going to do? We're almost finished with Matt Baltier. He's getting along okay, but I sure would love to just do some more little scar revisions and remove a dog ear here or there or something, And he disappeared. Well, geez, I said, God, what can I do? Well, I lost him. So I came back to the States and tried to find him again. I came back a year later, tried to find him. By then his father had been surveyed out of the Army, and I could not locate him. So finally I gave up, and the years went by. 50 years after his original surgery, I got an email. It said, are you the doctor that saved my life in Italy? Signed, Matt Baltier. I said, oh, for God's sake. So I immediately, of course, emailed him back, found he was down here in Massachusetts. He immediately came up here. By then he was married, and he still had scars, of course, on his face, but was doing pretty darn well in general. He'd been a good kid, and he became a good man. And I said, you think we could still do some scar revisions here? No, he said, these scars are okay. He said, I don't mind these scars. He said, I now work over in the prison. He said, and the guys out there love me with these scars. He was that kind of a guy. Anyway, it was wonderful to have that happen, see? And I said, that is the kind of reward you get if you go into surgery and you've helped someone, and then years later, when they've grown up here, they come back to thank you for what you've done and so forth. So then I put him in the hands of Joe Rosen up here at Dartmouth,
Sure.
who had trained under me,
Right.
see, and he has taken care of him ever since.
That's reconstructive surgery.
That's reconstructive surgery.
That's where you make a change in someone's life.
Yeah, that's true.
Well, as you know, we're talking about the 75th anniversary of the board coming up in San Francisco next year, and you'll get an invitation, and so will all the past directors of the board. Is there anything else you'd like to share with us that we may have forgotten to ask you?
No, but I'll tell you the other thing that I say at the end of my talk to convince students to become physicians.
Okay.
And that is, when I was head of surgery at Stanford, I've been there for several years, I got a call from LAMP, the Latin American Mission Project. It's a Catholic group in San Francisco. And they said, Dr. Chase, we have a young boy, he's now 9 years old, and he's got a wide open cleft of his palate and lip. He's never been to school. His mother walks around with him with a bag over his head and holes for his eyes. Could you operate on him if we got out here? I said, oh, are you kidding? Of course. We'll take care of him. There'll be no charge. I'll talk the hospital into taking care of him. He can come up and live with a Latin family in San Jose, very close by. And sure enough, he did come. We operated on him. He was a hell of a good kid, but we operated on him, did his lip and palate in stages, and he stayed around living in the area during that time, and he got, fortunately, a very nice result. He went back to Mexico essentially totally rehabilitated. I mean, he went to school and everything was going well. Well, the Latin American Mission Project came to me and said, hey, we've got a lot more kids like this down here. Is there a way you could go? And I said, well, I'll tell you what. Why don't you get a collection of them together, and we'll come down there instead of them coming up here, and we'll take a look at them, and if they need something we can do for them, we'll try and get them to come up and we'll take care of it. So I took my chief resident with me, Donald Laub. Donald Laub and I saw a line of kids that needed help, see, and Laub simply caught fire. He could not believe what he was seeing. And that was the beginning of Don Laub's experience, which led to Interplast, which became a huge organization, as you know, and became a very important part of our residency training program, because we were sending residents off to all the Latin American countries and finally to Asian countries, and it ended up as a huge success. And I show them pictures of this kid and the cleft repair and then what happened, because then a whole group from Mexico, Mexicans, came up and invited me to come down to San Jose. I went down there and they had this wonderful party for me. I didn't know what was going to happen. And they had this beautiful painting of a Mexican Indian lady with her baby on her back or something like that. It was really an exciting thing for me, and for Don, of course. And of course, I turned the picture over to him later on, and finally it went to Interplast. But it's that kind of thing that is so rewarding when you're in a specialty like ours, you know, because if you're a general surgeon and you take someone's appendix out, what have they got afterwards? A scar on the abdomen, but, you know, they haven't really done very much.
But they're alive.
Yeah, they're alive.
You know, there's one other question. As I remember, as I was getting into this specialty, was the film that you did on anatomy of the hand.
Yeah.
How did that come about?
Willie White and I started that. Willie was interested in doing this movie, and he talked the anatomy department into nabbing one of the fresh cadavers that came into Pittsburgh. And Willie called me and he said, we're going to make a movie. We went over and he had all the movie making stuff, and we made little signs and all the stuff that you see in that movie, and did the bulk of that movie there. Then when I got to New Haven, the movie hadn't been finished by then, and that's where we did the part with the pulleys and all that kind of stuff, and put it all together, and it ended up as anatomy of the upper limb, and I can't believe it, but I still get requests for that film. I cannot believe that, but people want it. I can't seem to get a good digital copy of the movie. I've still got copies of it, but I can't get a good, to me, a satisfactory digital copy. But anyway, that's how it came about.
Yeah, that's good. Terrific.
Dr. Chase, thank you.
You're welcome.
On behalf of the
It's a great
specialty.
pleasure for me to meet with you folks.
On behalf of the specialty and the American Board of Plastic Surgery.
Thank you.
Excellent. Excellent. Now, my